These abbreviations are used during the video.
We position the ultrasound probe longitudinally over the dorsal aspect of the DIP joint, allowing a clear view of the extensor digitorum communis tendon enthesis next to the joint. Dynamic flexion and extension of the DIP joint helps us check tendon integrity, better visualize sliding layers between structures, and detect subtle synovial inflammation. We remain in the same position with a longitudinal view over the dorsal DIP joint and switch to Doppler mode. Physiologically, the distal phalanx and nail bed commonly show prominent vascular flow with Doppler signals. By contrast, Doppler signal is not expected within the tendon substance, at the enthesis, or within the joint synovium. A Doppler signal localized at the bony insertion or within the synovium is indicative of active enthesitis or synovitis. Now we position the ultrasound probe transversely over the dorsal aspect of the distal phalanx, just distal to the DIP joint, where the cartilage of the joint is no longer visible. Here, the fibrillar structure of the very distal end of the extensor tendon can still be identified, overlying the distal phalanx. This view captures a very small anatomical section and depicts the enthesis complex, the region where the tendon attaches to bone, comprising tendon fibers, fibrocartilage, and the adjacent bony surface. We assess for tendon thickening, bony irregularities, or calcifications within the enthesis, as well as its relation to the surrounding soft tissue. We keep the probe in the same transverse position and switch to Doppler mode. Consistent with the longitudinal view, Doppler signal is not expected within the tendon substance of the enthesis complex. The Doppler signal seen palmar to the bone in this example is a reverberation artifact from the dorsal digital vein. It appears as a false signal caused by repeated reflections of the ultrasound beam. In this image, we see a fine hyperechoic linear structure at the insertional region of the extensor tendon. This finding corresponds to an enthesiophyte, as may occur in psoriatic arthritis. In contrast, osteophytes arise from the joint margin and are not located within the enthesis. On ultrasound, distinguishing an enthesial bony proliferation from a joint margin osteophyte helps differentiate DIP joint involvement in psoriatic arthritis from active osteoarthritis.